Hi guys. So today's teaching session is on seizures, just talking about early recognition, early management steps, and putting out a call for help early doors to try and make sure that you've got the support that you need in that situation. Hi guys. Objectives involve recognizing different forms of seizure activity, prompt assessment of the patient, and the need for putting out a emergency call or a crash call, early management steps, and further management that you'd consider for any seizure patient. So, you've been bleeped about a patient. You've received a bleep from a nurse in ED. They inform you that a 25-year-old's just been admitted to Majors with a chest infection and has been started on the appropriate antibiotics by the ED doctors. He informs you that the patient is looking a bit pale and clammy, and he's just on a set of obs, and his EWS score is 6. So you let the patient know that you're on the way. You let the nurse know that you're on the way to assess the patient. So defining seizure activity is aberrant cerebrocortical electrical conduction resulting in neurological dysfunction. So symptoms can include behavioral changes or motor manifestations, what you'd more typically see. Epilepsy is defined as 2 or more unprovoked seizures, and status epilepticus is a seizure lasting more than 30 minutes or repeated seizure activity with no regain in consciousness. Looking at the etiology, you can use different systems, one such as the vitamin sieve, each letter standing for a different root cause. So V, vascular, stroke, AV malformations, I, infection, meningitis, or encephalitic changes can result in seizure activity, T for trauma, head injuries, autoimmune conditions, metabolic conditions with hypoxia, or metabolic states, I should say. Hypoxia, hypoglycemia, and hyponatremia are the most recognized forms. Idiopathic causes or neoplastic. So looking at malignancies, whether that could be a primary malignancy in the brain or secondary malignancies. Other causes as well, things to consider listed down there. You can get febrile seizures, often seen in pediatric patients, and there's other conditions as well. So drug overdose is another key one to kind of look out for in ED settings. So assessing the patient. You go down and see the young gent, you look at the airway, they're still talking to you, talking in full sentences, kind of telling you that they're not feeling too well, feeling quite hot and shivery. Their breathing, you assess them using a stethoscope, you have a listen to the chest, they've got good air entering bilaterally, there's equal expansion of the chest, and their oxygen saturation is actually 93% on air at this point in time. So move on to C. So their cap refill time centrally is under 2 seconds. Note that the heart rate is up at 120 and the blood pressure just cycles and you get a reading of 104/72, so bordering on hypotensive. In terms of assessing for D, they do look quite sweaty and quite feverish. You get a blood glucose monitoring recording, and that's 5.6. Pupils are equal and reactive to light, and there's no other obvious injury. So they're being treated for the chest infection, and they seem quite unwell with that at this point in time. So just managing what you found on your A2E assessment, and we've kind of highlighted it here in red. So the airway is clear. Breathing wise, you've spotted that they're 93% on air, so it's probably a good idea to start them on high flow oxygen in the acute setting. So always 15 litres via non-rebreathe mask, and then you can titrate that accordingly depending on how the patient responds. From a circulation perspective, you can see that they're tachycardic and their blood pressure is a bit low. It's a 25-year-old male, so again, blood pressure being low could just be a normal physiological change. However, in this context, given that they're unwell, you want to be assessing their fluid status. And if you think that the patient is dry or dehydrated, then you probably want to consider giving fluids, especially given that in this situation, they are tachycardic, their blood pressure is low. And then in terms of assessing the D part of the ABCDE, is there any evolving neurology? So for considering we're talking about seizures, you might not do this for every single patient, but if you're worried about seizures, you do want to be doing at least a basic neurological exam, and that can just be a gross assessment of the cranial nerves and looking at power and reflexes in the upper and lower limbs. So as you're prescribing the fluids and requesting further tests at the computer, you hear the emergency call bell go off and realize it's for your patient. You arrive at the bedside and you see that the patient is actually seizing. So you can see that the head is stuck in extension, both their arms and legs have stiffened, and they are jerking in rhythm symmetrically. So again, talking about management again, you need to go back to your A through E assessment at all times, especially in the acute settings, And in this case, as a new F1, call for help. I think if you're ever feeling out of your depth, or you're unsure what's going on, or you don't know exactly what to do next, then definitely call for help. In a seizure patient, you're always at high risk of losing their airway. So again, you're going to need the relevant specialties, anaesthetist or ITU there to help provide the care needed. So again, put out the twos, get the crash call out early if you're at all worried or you need help. And in this kind of situation, you should be looking to do that. And then the first thing that you can do is actually start the timer. So you want to start a stopwatch so you know how long the patient has been seizing for. In this case, you're quite lucky you're there by the bedside when the call bell's gone. So you can just do that by yourself or get one of the helpful staff there to do that for you. And you move on to your A2E assessment. So airway, you would continue with the 15 litres via non-rebreathe. They're obviously not responding anymore because they're currently seizing. Another thing you can consider is once you've got the crash trolley there, you can consider using a nasopharyngeal airway adjunct as an initial intervention if you do need to help support the airway further. And if you've got staff members with you, you could do a head tilt jaw thrust as well to keep the airway open and make sure that the oxygen is going through. And you can keep monitoring that as well with the relevant monitoring. You can also consider suction if necessary, but just always be careful. You don't want to be putting your hand into a seizing patient's mouth. Breathing wise, you want to be monitoring their oxygen saturation so that you can see whether your A part of the assessment and intervention is working. And if you've got waveform capnography, that's always really helpful as well, because it means you will be able to tell whether you're adequately oxygenating the patient. Then for C, you want to get them on cardiac monitoring with their BP cycling regularly, and you want to gain access, if able, ideally to spots for giving medication or fluids, and also in this situation, you want to be taking bloods, cultures, so you can start your investigations. Talking about assessing the neurology as a part of a D, you want to look at their pupils. So the main reason there is you want to check if they're reacting still, if either or is fixed or changed in size, because you're looking for cranial causes, and that could be secondary to a bleed. And there is other causes as well, as discussed previously. Also check their blood glucose. Like we said, metabolic changes can also cause them hyperglycemia. And another key thing to note here is, are they an alcoholic? Can you see that from their past medical history? Or is that a history that's been obtained by the EDSHO who's clerked the patient in? Or is there a collateral history you can get in there, and then does anyone know? Again, this is all just part of assessing the causes of why the seizure is happening. In terms of positioning the patient, ideally you want to have them in the lateral position, but you don't want to be forcing the patient to move around, especially whilst they're mid-seizure, because you're at more risk of harming them. Talking about management further on from that, ideally by this point you've got your team with you, MedReg will be there along with the appropriate staff that you need to help. But just looking into seizure management, most seizures tend to terminate within 5 minutes. You want to follow local guidelines, and they will advise appropriate medication. Typically, most trusts at the 3 to 5 minute mark, if the seizure hasn't stopped, you want to consider giving lorazepam 4 milligrams via the IV route. If you can't do that or you haven't got access, then typically it tends to be IM, buccal midazolam, or PR diazepam. And then if the patient continues to seize, again, this is more senior intervention, but just for your knowledge, it tends to be that the next step will be considering giving loading doses of levetiracetam, so Keppra, or valproate, depending on the patient age and group. In a 25-year-old male, there's probably not too many contraindications as long as there's no allergies. However, it tends to be Keppra that we see most commonly in practice. Any patient seizure that goes on for 5 minutes, you're now running a high risk of status. And this is, again, going to require complex senior input and support, which is why we said you want that early help call put out so that you've got seniors there available to help. And then moving on from kind of seizures to the post-seizure period, you're thinking about the post-ictal period. This can last a few hours. You just want them on monitoring still, likely neuro-obs every hour or so for the first 4 hours at least, just making sure that they aren't having further subclinical seizures, which just means that they could be having seizure activity without any obvious signs of seizing. You also want to gain a collateral history if you can, to make sure, because the patient won't be able to respond in this period, but you want to ask next of kin, is this the first time that the patient has seized? Have they ever had any previous seizures? As this will help guide your next steps of management as well. You will also consider, and this will again be done under the direction of neurology, further imaging and potentially a lumbar puncture. So again, this is usually looking for the causes of seizures and also for monitoring purposes as well. And a key thing to always remember is that patients or their families will need to be told to inform the DVLA, because seizure activity will mean that you will be disqualified from driving for a certain period of time, depending on the seizure activity, the kind of seizure, and whether it was provoked or unprovoked. The rules are all online. You can find them on the government websites. So that's it. That kind of covers everything about seizures that you need to know in the acute setting. So it's about recognizing a patient that's seizing, making sure you're doing a thorough A2E assessment, and ensuring that you keep their airway supported as best you can with the implements that you have, getting the crash call out early, and giving them the medications early, ideally that lorazepam 4 milligrams within the 3 to 5 minute mark if they are still seizing at that point.